Good morning, everybody. I am Marco Ronda from Genova, Italy, and welcome to Guide Institute for this new lecture or lesson regarding the GBR procedures. In the first lesson, we talked about the surgical approach. And we divided one and two stages approach. One stage approach when we have to increase the bone volume, but at the same time we can insert the implants. And the second surgical approach, two stages approach, when the residual bone is insufficient to insert the implants at the same time, or the residual bone doesn't grant the correct axial insertion or osteotomies of the implants, for the implants. Now, with the second part, we will talk about other chapter, other topics, and now we discuss about the GBR guidelines. The GBR guidelines are the rules that the surgeon has to be followed in order to guarantee the surgical predictability of the treatment, the surgical treatment. The first is the stabilization of the blood clot. This is an old concept. We received this information regarding the biological rules in the far 1991 age, in a period where Dallin described the GBR procedures and the biological rules for the bone regeneration. And these rules are changed. And today we have to follow perfectly these rules in order to get a good bone regeneration. The first, the blood clot stabilization. We can stabilize the blood clot with the fixing of the membrane on both sides. It's very important that the fixing of the membrane stabilize perfectly the barrier on top of the material, in order to create a perfect contact between the material below the membrane and the membrane on top of the material. And the stabilization of the membrane can be done with some different system. I advise that in the lower jaw, where the residual bone is very hard, very hard, and the difficulties for the fixing of the tacks are very high, I advise the using of the self-tipping screws, especially in the lingual side. And sometimes I think that the fixing of the membrane with the tacks could be done on the buccal side, but on the mesial part, on the anterior part of the bone, where we could find a bone that the resistance to the penetration of the tacks is limited. Instead, in the posterior area of the buccal side, the bone is very hard, and in this area I think that the best system for the stabilization of the membrane is the safety pin screws. Then the protocol wants the stabilization of the membrane on the lingual side. And in this way, we can organize this difficult step, because the stabilization of the membrane on the lingual side is very difficult. We don't manage to work easily, and we have the tongue, we have the curve of the lower jaw, and so there are some different conditions that determine a lot of difficulties in the fixing of the membrane. And of course, it's important that these procedures is done when we didn't graft the material. And for this, it's important the fixing of the membrane as a first step on the lingual side. And then the second reason is because in this way we can protect the contact or hypothetical contact of the saliva and the tongue against the material. Because in this phase, when we'll place the material in this area against the residual bone and around the implants, the contamination of the material is a critical situation. But if we fix the membrane on the lingual side, the membrane can isolate the material from the contamination, the contact with the saliva and the tongue. Then we have to perform the osteopromotion perforation. The osteopromotion perforation are very important because we know that the perforation of the bone cause a damage of the bone. And when we damage the bone, we activate the osteoclast cells. The hematopoietic cells is the activator of the osteogenetic process and the osteoblast activation. And for this, I prefer to damage the bone with the osteopromotion perforation and the using of the scraper on top of the residual cortical bone. And then because we can allow the passages of the new vessels from the cancellous bone to the environment where we grafted the material. And then because the osteogenetic process that we know is ruled by the endosteum activity and periosteum activity needs of the perforation in order to create a communication between the cancellous bone and the space where we want to get the bone regeneration. Another important thing, another guidelines is the correct relationship between the residual teeth and the membranes. And this is mandatory if we want to get a good seal around the last tooth. And for this we have to shape and we have to fix the membrane in order to leave a thin portion of the residual bone around the last tooth adjacent to the defect, and allows the contact of the flap against this portion. And in this way we can develop the junction between the periosteum and the bone, the residual bone, that will leave free around, you can see here, you leave free around the last tooth or the teeth. And in this way we can develop the periosteum and the connective tissue attachment. And the connective tissue attachment against the root, well cleaned, and the periosteum attachment against the residual bone. And this is the guarantee for a good seal around the last tooth. And this is the place where we can play the success of this technique, this surgical approach. Because through the contact between the flaps and the tooth, through this junction, we can have the passage of the bacteria and the contamination of the graft material or membrane with defection and with the fail of the surgical procedures. And for this we have to close perfectly the soft tissue on top of the membrane, but at the same time we have to guarantee that the soft tissue after the closure are placed perfectly in contact with the bone. It isn't sufficient to leave a residual portion of the bone around the last tooth, and it isn't sufficient to close perfectly the soft tissue on top of the membrane if we don't manage to place correctly the soft tissue against the bone. In this way we can get the periosteum attachment, we can get the connective tissue attachment. Differently, if the flaps should leave in a coronal position, we could have a space between the inner part of the flap and the residual bone, and we lose the opportunity to have the periosteum contact. And probably the flap will have a more coronal position, and the flap will be in contact with the crown, not with the root, and we don't have the opportunity to create the second seal, the connective tissue seal or the connective tissue attachment. Another GBR guidelines is the buccal fixing of the membrane. We have to fix the membrane on the both sides, and after the fixing of the membrane on the lingual side and after the grafting of the material, we can close the membrane on top of the material and fix the membrane on the buccal side. This is a delicate phase of the GBR because we have to create a good contact between the material and the membrane. We don't have space between below the membrane. And for this, we have to do two things. First, we have to graft the material with an ideal shape that is similar to the shape of the membrane that we perform. And second, that during the adaptation of the membrane on the material, we have to create with our finger a pressure of the membrane against the material from the lingual on top of the crest, and then create a tension of the membrane apically and fix the membrane on the basal side. First on the mesial part and then on the distal part. And regarding the strategy of the fixing of the membrane on the lingual side, I forgot to tell you that the first self-tipping screw that we have to place is on the mesial lingual side, and then the second on the distal part of the lingual side. And after the first self-tipping screw, we can modulate the position of the membrane on the ridge. And when we managed to stabilize the perfect relationship between the shape that we gave to the membrane and the defect, we have to place our finger on top of the membrane. Below the membrane there are the implants, the heads of the implants, and stabilize the membrane with the left finger. I work normally with the right hand, and fix the second self-tipping screws on the distal part of the lingual side. In this way, we can stabilize perfectly the orientation of the membrane. And another thing, very, very important thing, is that if you want to elevate the predictability of the surgical treatment, GBR surgical treatment, you have to work with a good soft tissue, good quality of the soft tissue, a good vascularization of the soft tissue, a good maturation. It means that if you want, you can apply the GBR at the same time of the extraction of the roots or the debridement of the inflamed tissue, if you want. But you have to know that the predictability of these techniques is reduced. You have to know that the opportunity, the possibility to have an early exposure of the membrane or infection of the graft material is very, very elevated. And for this, you have to treat the case before the GBR in order to eliminate all elements of infection like roots or teeth, and with the complete removal of the inflamed tissue, you can create an ideal condition for a good health of the soft tissue. And during the removal of the teeth or roots or the inflamed tissue, my experience, my behavior is the feeling with a gentle feeling of the alveolar site with the fibrins and a closure of the alveolar side with the crossed sutures in order to help the stabilization of the blood clot. But I don't want to close for the first intention the flaps. I don't want to gain something of bone with the grafting of the material. I would like to maintain the integrity of the periosteum, and for this I don't like to close the flaps on top of the alveolar site. Even if, because I am sure that I cannot gain anything. If you wanted to gain something with the closure of the flap, you have to place a membrane, you have to graft the material, but it's too expensive, and then the quantity of the bone that I can get is modest. And then if I have already planned the bone regeneration is not useful. The bone regeneration with the absorbable membrane at the time of the extraction of the roots or teeth. And for this, my approach is the extraction of the roots, residual roots, and the extraction of the teeth and the debridement of the inflamed tissue, and the filling, the soft filling of the alveolar site with the fibrins, and the closure of the alveolar site with the crossed sutures in order to stabilize the blood clot. 3 months later, this is the situation. You can see that the tissues are perfect. They obtain a good maturation, a good vascularization, a good stability, and they can support the stress of passivation of the flaps that we have to perform during the advancement of the flap in order to close for the first intention the GBR on top of the membrane. And this is the last guideline, the presence of the residual peak bone. I have already talked about the importance of the peak bone. And when we have the integrity of the peak bone, we can regenerate what we want. It isn't a limitation, the defect. 10, 11, 12, 30 millimeters. In the upper jaw, I regenerated 15 millimeters, but I had the integrity of the peak bone, because in this way have I already discussed and described, we can place the membrane in order to leave a modest thin slice of the residual bone around the last tooth and grant the connection of the periosteum in this area, and to grant the seal and the attachment of the periosseum against the bone and the connective tissue against the roots.